Hello, everyone. My name is Natalia Saukova, and I'm International Scientific Officer of IADS. It is my honor and pleasure to welcome Dr. Goncalo Carames today with us, who's going to lecture us about mucogingival surgery using VISTA technique, and we may start. You have rights to ask questions afterwards. He'll be really glad to answer them, and this webinar will last around 1 hour and a half. So enjoy.
So hello everyone, welcome to this webinar. So first of all, I'd like to thank the International Association of Dental Students for this kind invitation. So during my presentation, I'm going to talk about mucogingival surgery, the etiology, diagnosis and treatment, and especially treatment with the vestibular incision subperiosteal tunnel access, which is a technique that was developed recently here at University of Southern California. But first, before I start my presentation, I would like to introduce myself. So I come from Portugal, so I'm originally from Lisbon, Portugal, where I lived, and I studied at University of Lisbon. So I was also a dental student. I was in the same situation as many of you not a long time ago. So I graduated in 2013. And I have the great opportunity to work at the Implantology Institute in Lisbon for 3 years. And after that, I came to USC. So I'm currently doing the specialty program here at University of Southern California. It's a 3 years program, and it's a combined periodontology program and also a master in craniofacial biology. And I'm lucky to have great mentors, great colleagues and friends here at University of Southern California in Los Angeles. So a quick video of USC.
University of Southern California, a place like no other.
So before I start my presentation, of course, I would like to acknowledge my mentors that had a huge influence in the way I see dentistry, and especially periodontology. So first of all, my father, Professor João Carames from Lisbon, and Dr. Zade, Dr. Kian Carr, Alan Friedman, Seiko Min, and Dr. Safarian, all amazing faculties that I have at USC, and I have learned a lot with them, and they have definitely influenced the way I see dentistry today. So let's start with mucogingival therapy. So during my presentation, as I said, I'm going to show some of my cases that I have been doing here at USC, and also I'm going to describe the technique that was developed by my program director, Dr. Zade, for the treatment of mucogingival defects. But it's important to have the notion that mucogingival defects is not just associated with gingival recessions. So as you see, and if you take a look at the definition of mucogingival therapy, it includes both non-surgical and surgical correction of the defects in morphology, position, and the amount of soft tissue and underlying bone. So you can see that there are many applications of mucogingival surgery. It's not just for the treatment of gingival recession. It can also be used for soft tissue augmentation around both teeth and implants, also for surgery of the frenum, so frenectomies. Also, we can do canine exposures and other tooth exposure. So you can see it has many applications. And in this case, in this presentation, I'm mainly going to describe 2 types of mucogingival surgery. So I'm going to start with root coverage procedures, and then we're going to talk about frenal surgery. So let's start with root coverage procedures. So first of all, what are gingival recessions? What's the definition of gingival recessions? So gingival recessions, as many of you probably know, is the displacement of the soft tissue margin apical to the CJ, with, of course, the exposure of the root surface. And this type of problems, it's actually very prevalent. You can see that according to Albander, we have more than 1 millimeter recession in 58% in individuals 30 years and older, and increase with age. So you can see it's very prevalent. So before we have to understand, before we think about the treatment, we have to understand what's the etiology behind the gingival recessions. So I like to divide the etiology of gingival recessions in two groups. So first we have the recessions, which are associated with pathologic alveolar bone loss. And we have periodontal disease and invasion of the biologic width. And then we have recessions associated with non-pathologic alveolar bone loss. So let's have a look at each one of these etiologic factors. So first one, periodontal disease. So if you take a look at this case, you can see that the patient has, of course, gingival recessions, but that's not the only problem that we see here. So in this figure, we can see that we have also severe attachment loss, severe bone loss. So if we plan to treat a case like this, is it favorable to cover these roots? As you will see in my next few slides, of course it's not, okay? So that's why it's important to see each case, because not all cases are suitable for the treatment of mucogingival deformities, and in this case, gingival recessions. So you can see this is one of my patients. He has generalized aggressive periodontitis, a very severe case that I have. Most of the teeth are mobile. And of course, we have severe bone loss, which is associated with gingival recession. So the other, one of the other etiologic factors is the invasion of the biologic width. So here you can also see one of my patients. She's a very young lady, and she had a fracture in this tooth. So tooth number 9 in the American system, in the European one, it's 21. So you can see that the restoration was very deep, and it was causing this persistent gingival inflammation, and you can see the gingival recession that we also have on tooth number 9. So here in this case, I did the orthodontic extrusion, but this is just to show another etiologic factor that can cause gingival recession. And then we have mechanical trauma. It's probably one of the most widely causes of gingival recessions is those patients that have a very good oral hygiene, but they have traumatic tooth brushing. So they are so concerned about brushing their teeth that they traumatize the gingiva, and that can cause gingival recessions. Again, tooth position. So tooth position is also can cause gingival recessions, especially if the tooth is outside the alveolar housing. So you see a lot cases like this, for example, in the lower anterior, where you have one of the teeth that is too buccally positioned. So sometimes it's even outside the alveolar housing, and that can cause gingival recessions. Also, in patients that had previous orthodontic treatment, it's very common to see those cases where we have gingival recession because the teeth were placed too buccally and outside the alveolar housing, and that causes gingival recession. Then we have the anatomic factors, so dehiscences. So these can also, of course, cause gingival recessions, this absence of bone. And then we have the plaque retention factors. So in plaque retention factors, we can include defective restorations that cause excessive accumulation of plaque, and also the frenum. So the frenum, depending on the type of frenum, and we're gonna talk about that. Some type of frena are pathologic, and it's indicated to have them extracted. So what are the possible consequences of gingival recessions? So one of the most prevalent consequences is dentin hypersensitivity. This is very prevalent, but it's important to know that to treat patients just because of dentin hypersensitivity can be risky. If you take a look at the evidence and the systematic reviews, we have one from Douglas Oliveira that clearly shows that although the treatment of these gingival recessions can reduce dentin hypersensitivity, in many cases you are not able to completely eliminate the dentin hypersensitivity, because dentin hypersensitivity in these cases usually comes from the CJ. So in many cases you are not even able to have complete root coverage. So it's always good to explain our patients that dentin sensitivity might not go completely away just with the treatment of gingival recessions. So another problem, which is of course a major concern for our patients, is aesthetics, especially when we have patients with a high smile line, like this case. Of course, having gingival recessions can have a negative impact in their smile. Root caries. So root caries is also a problem when we have gingival recessions, because of course in patients that are caries prone, having the cementum exposed, dentin and cementum exposed to the oral cavity might increase the risk of developing these root caries. And also abrasion. So we know that the dentin and cementum, they don't have mechanical properties as favorable as the enamel. So of course the patient, when he brushes and all that, and brushing the root surface, can cause abrasion. So the question is, should we treat the gingival recessions, and when should we treat these gingival recessions? So here you can see a case that the patient came to advanced perio here at USC, and the patient, we saw the patient for the first time like this, and then the patient went out of the city, and when she came back, this is what happened. So we can see the progression of these gingival recessions, and the question is, should we always treat gingival recessions? And the answer, of course, is it's no. It depends on the situation. So you have to evaluate the risk factors of each patient. So if you look at a patient and you see that the patient has gingival recessions and he has a thin biotype, he has a shallow vestibule, she or he has a traumatic tooth brushing. So all those factors increase the risk of progression of the gingival recession. So the important is to evaluate each patient and see if there's the risk of gingival recession progression or not. So if we take a look at the evidence in the literature, if you look at this study, which is a very good study, a systematic review and meta-analysis by Dr. Chambron and Tatakis, and if you take a look at these charts, their conclusion was that if you don't treat gingival recessions, there's a high risk of further progression. So they found that in 80%, almost 80% of the cases, they have further progression of the gingival recessions. So when we think about the treatment of gingival recessions, we have to evaluate each case. Of course, not all cases are favorable for the treatment of gingival recession. So usually this is the most widely classification, the Miller's classification for gingival recessions. And when we have a class 1 gingival recession, it's the one that we consider the most favorable to treat. So we have, of course, gingival recession, but usually that gingival recession does not extend beyond the mucogingival junction, and we don't have attachment loss. Class 2 is those typical cases of lower anterior teeth, patients that have previous orthodontic treatment, and what happens is the tooth stays outside the alveolar housing and causes these recessions that goes beyond the mucogingival junction, but you don't have interproximal attachment. So although you have those deep recessions, they are still favorable to treat because you don't have attachment loss. And then we have class 3 and class 4, which are not as favorable as class 1 and class 2. Why? Because you have attachment loss. So in class 3, that attachment loss is not as severe, and in many cases we can treat still with a good outcome. When it comes to class 4, gingival recession is not predictable. So in many cases, when we have class 4 gingival recessions, and if the tissue is very thin, we can increase the thickness, but we cannot expect to have much root coverage because we have severe attachment loss. So you have the different classifications, the different classes, and of course they have different outcomes. So class 1 and class 2, you can expect 100% root coverage. Class 3, you can expect from 50 to 70%. And in class 4 is not anticipated. So here you can see 2 of my cases. In the first image, you can see a class 1 gingival recession, which is predictable to treat. But in the second figure, you can see a class 4 gingival recession. And you can see this is a case of aggressive periodontitis. You can see the severe attachment loss that these teeth have. So of course, in this case, it wouldn't be possible to have root coverage. So if again we take a look at the evidence, you can see that in class 1 and class 2, the mean root coverage that we can achieve is 80%, according to the systematic review by Chambron. In class 1 and 2, so the more favorable gingival recessions, because you don't have attachment loss, you can have a mean root coverage of 80%. So the blue column. If you take a look at the green one, you see that in just 46.6%, you have complete root coverage. So you see that even in class 1 and 2, the more favorable ones, you can have a mean root coverage of 80%, which of course is high. Just in 46%, you have complete root coverage. So even in those perfect cases, in many situations, you don't have complete root coverage. If you take a look at the class 3 gingival recessions, you usually have a mean root coverage of 69–70% with a percentage of complete root coverage of 42.8%. And another question that we have when we think about treating the gingival recessions is, do we need to graft or not? So I recommend all of you to read this paper. It's a very good paper. It's a systematic review from Dr. Chambron and Tatakis, and it basically answers many of the questions that we have when we want to treat gingival recessions. So you can see in their conclusion that they say that subepithelial connective tissue grafts provide the best outcomes for clinical practice because of their superior percentage of mean and complete root coverage, as well as significant increase of keratinized tissue. So this is in line with the studies, like the studies from Cairo, that show that long-term, if you graft, you have lower risk of relapse. So because you graft and you increase the thickness, the risk of having further progression is smaller. But you don't have to graft in every case. So it all depends on each situation. So if you have still a good band of keratinized tissue, usually 2 millimeters of keratinized tissue, and you have a thick tissue, in many cases you don't have to graft. On the other hand, if you have a very thin biotype, it's probably better to graft to avoid further relapse. So surgical techniques. So we know that we have many surgical techniques for the treatment of gingival recessions. And here at USC, at University of Southern California, we, of course, are able to do all of those techniques. But during my presentation, I'm mainly going to focus in one of those techniques, which is the VISTA technique. So the vestibular incision subperiosteal tunnel access technique is a technique that was developed recently, so in 2011, by Dr. Zade, my program director here at University of Southern California. And I think it's a very good technique. So this is Dr. Zade, the inventor of the technique, and also the paper where he described for the first time this technique. And of course, we at USC, we do all the techniques. We do coronal advancement, we do tunneling techniques, and when it comes to tunneling techniques, you have different tunneling techniques. What I'm going to show in this presentation is how is the VISTA technique, the step-by-step, and also the clinical application. So VISTA can be used not just for gingival recessions, but it can also be used for other types of mucogingival surgery. So in the next slide, I'm going to show the VISTA step-by-step. So the first step, I don't know if you are seeing the video or not, but the first step is root odontoplasty. So we know that root prominence, and we have been doing studies here at University of Southern California that clearly shows us that root prominence has a negative effect in the treatment of gingival recession. So when we do this technique, the first step is root odontoplasty. And then we go ahead with our vestibular incision. So you see it's a full thickness flap incision that we do usually in the midline. And then we see the tunneling that we are creating. As I said, it's completely full thickness, so we go until bone. And we use this tunneling to coronally advance our gingival recession. So here you can see we just use that small incision that we do in the midline, and with that small incision, we coronally advance our flap. The most delicate area when we are doing this tunnel is the mucogingival line. So the transition from mucosa to attached gingiva is probably the area where there's the highest risk of perforation. So you have to be very delicate when we perform that. So after you have your incision and after you have your tunneling, what we do is we use the bonded sutures. So I'll show also in my clinical cases, this type of sutures is very useful. So we usually use polypropylene 5 or 6O, usually 6O, and it's very useful because it allows us to keep these sutures in place for up to 3 weeks, and they really help with the coronal advancement. So we suture we have the bonded sutures, and then you can see we just have to wedge the teeth, and we bond the sutures to the enamel of the buccal surface of the anterior teeth. And that way you can have the coronal advancement. So here you can see we are bonding the sutures. It's technique sensitive, so of course, I would say probably the suturing is the hardest part of the technique, but you can see now the coronally advancement that we are able to achieve with these bonded sutures, and it really works. It's very effective. And now that we have the coronally advancement, we are ready to harvest our graft. So we go to the palate and also to the tuberosity in cases of multiple gingival recessions, and we thin the graft, so we have a thick tuberosity. The tuberosity, the quality of the tissue is very good. So usually the palate, the quality is not as good because we have more fat tissue, and because we have more fat tissue, it causes more shrinkage. That way, we, in cases of multiple gingival recessions, we go both to the palate and to the tuberosity. So the tuberosity you've seen, the palate, we go usually from second molar to lateral, and then we harvest a thick graft to try to cover the multiple gingival recessions that we have. So in this case, we use the VISTA instruments to elevate our graft, but it can also be used with a periosteal elevator. And then we use these crisscross sling sutures to stabilize the bleeding and also to close the incision. Although this is very important, that when we suture the palate, you see the bites in the palate, they are very deep. So it's very important that when we do this suturing, we don't suture it too close to the margin. Because of course, the closest we are to the margin, the more compromised is the blood supply. So it's very important that we try to suture it away from the incision to avoid having necrosis of the margin. So now we go to the last step, which is to place the graft. As you can see, we place the graft inside our tunnel, and the way we suture this graft, it's not complicated, it's very simple. So you can see from this sequence of pictures, what we basically do is the first bite is outside in. So we go from outside to inside the tunnel. And then once we are inside the tunnel, we take our needle from the vestibular incision. So that from in the midline, you see, we take out the needle, and then what we do is we give a bite inside the graft. We put the graft inside the tunnel in the area where we want to have the treatment of gingival recession, so to cover the root. And then finally, we go inside out, and we can tie the knot. And that way, you usually, depending on how long is the graft, we can do 2 or 3 sutures like this to have a complete stable graft. It's very important that our graft is stable. So that's very important that we, at least 2, if it's a long graft. So here you can see the video where we go outside in, then we get inside, and then we bite the graft, and we put it inside, and we tie the knot. So usually use also either polypropylene or a resorbable suture to stabilize the graft. So it's important that we do it at least 2 or 3 times to make sure that the graft is stable and it doesn't move during the healing. So usually polypropylene is the type of suture that we use for these cases. And we do the same thing on the other side. So as you see, one of the advantages of this technique, I would say it's one of the greatest advantages, is that you can do full mouth root coverage in just 1 surgical procedure. And we do that very often. So the advantages of VISTA. As I was saying, that I think it's one of the greatest advantages of this technique, is that allows us to do in 1 single procedure the treatment of multiple gingival recessions, and you can do the whole procedure just with one incision. So we do that vestibular incision right at the midline, and with that small incision, we can cover a whole maxilla or mandible just with one incision. Of course, it's technique sensitive, so you have to learn the technique, but one of the advantages is that compared to a coronally advanced, when you have to raise a flap, is that here you leave the papilla, the interproximal attachment, so of course that improves the blood supply and reduces the risk of black triangles. And also, I think one of the advantages of this technique compared to techniques where we have to do the intracellular tunneling is that all the pressure that we apply is far away from the gingival margin. So we know that the area that we don't want to compromise the blood supply is exactly the gingival margin. So with this technique, by doing the incision far away from the gingival margin, you can have the good coronally advancement without causing too much pressure in the gingival margin that could cause necrosis. So I'm going to show some of my cases that I have been doing here at USC. So I'm going to show a case where I didn't graft, and I'm going to show a case where I did graft. So this is my patient, OT. He is a 44 years old male Hispanic, and he was referred to the grad program of perio because he had a high smile line and he had recessions on especially the canine and premolars, and he didn't like that yellow color, and he wanted to have treatment. So as you can see in this case, it's a case where we don't have deep pockets. So the pockets in this case range from 3 to 4, and you can see we have gingival recessions, especially in the upper right quadrant, and for that reason, he wanted to have treatment. So if you, again, you take a look at the radiographs, radiographs are very important for us before we plan and before we perform the surgery. It's very important to see where is the attachment level to see, first to classify the type of gingival recessions that we have, and also to see how predictable it is, our treatment. So in this case, although he had some mild bone loss, was a favorable case, we always do at USC the periodontal risk assessment of our patients. So this is a tool that you can online and use it online. It's called periotools.com. And what it basically does is you can use your patient's information like age, number of teeth, the areas with bleeding, the percentage of alveolar bone loss. And with all these factors, you can evaluate the periodontal risk of your patients. So this tool is mainly useful to evaluate the recall visits of our patients. So, of course, when we have a periodontal patient, they are not all the same. So that some patients, they have higher risk compared to others. So it's important to see how should be the recall visit of each patient. So in this case was a patient of medium risk. So the suggested recall is every 6 months. But in some other cases, when they have high susceptibility, of course, the recall visits should be every 2 or 3 months. So this is a tool that we always use to classify our patients. So this is the preoperative picture of my case. So you can see that the recessions were mostly on the canine and premolars. And because he had a high smile line, he was not happy with having that yellow part, of course, the dentin exposed. So he wanted to have root coverage. As I said, in this case, he also had dentin hypersensitivity. But I warn you all that it's not prudent to guarantee that just with the gingival recession treatment, we're going to get away the dentin hypersensitivity. The evidence is clear and shows that yes, you do reduce the sensitivity, but in many cases, you are not able to completely remove sensitivity. So this case, the treatment of gingival recessions was first to avoid further progression, and second, because the patient had aesthetic concerns. So you can see, although we have gingival recession, we can still see that we have a good band, a good amount of keratinized tissue, and that's very important because it depends on that, depends if we're going to graft or not. So as I said, this is a case that I didn't graft. So when we do the vestibular incision, you see in this case, I did it between lateral and canine, because in this case, I was not doing a full arch root coverage. If I was going to do that, I would probably do the incision in the midline. But in this case, having this incision far away from the gingival margin, you have your tunnel and you have enough space to coronally advance. So you can see you do a full thickness flap incision, so you go until bone, and then you elevate the superiosteal tunnel, as you can see here. This is a very simple procedure, so you just have to, the hardest part, I would say, is the transition from the mucosa to the attached gingiva. That's the area there is the highest risk of having perforation. And also it's very important, when we create these tunnels, it's very important to go to the interproximal without raising the papilla. So the goal is not to elevate the papilla, but it's important to have enough reflection of the interproximal area. And for that, we use the VISTA instruments that help us a lot with that. And it's also very important that we have a tension-free coronal advancement. That's very important in soft tissue grafts. We need to have tension-free flaps. So you see, it's very simple. Now I have my suturing. You see that we use the polypropylene to have these bonded sutures. And you can see here, I didn't graft at all. It was just coronal advancement because we still had a good amount of keratinized tissue. So you see, it's a 3 steps procedure. It's not complicated at all, especially in this localized recession. So you do your incision, you create your tunnel, and then you suture. So these sutures, we usually try to keep them for 3 weeks to have the coronal advancement and to have the tension to avoid apical displacement. And in this case, the vertical incision, you can use either resorbable or non-resorbable. In this case, I used chromic cut, so resorbable sutures. So you can see, this is a very important point. So the polypropylene, when you cut the suture, it's very important to cut these edges. Otherwise, of course, the patient won't like to have the sutures too long. So it's very important, even with the blade, you can cut the edges to avoid any sharp edge. So this is a 1 week post-op. You see the origin of the patient is not good, but you see that everything is going well. There's no sign of infection. If you see 2 weeks, we still have the sutures in place and they are still creating some tension in the margin. And if you take a look at 3 weeks, you see that they are still in place, still functioning. And usually at this point, we take out the sutures. But I think one of the good advantages of this technique is definitely the suturing. So the suturing, of course, it's more technique sensitive. It's not easy to perform this type of suturing, and it takes longer, but it definitely makes a difference. From my experience, I've done probably most of the techniques. I think this is one of the great advantages of VISTA, besides, of course, avoiding raising the papillas, is this type of sutures that has a good effect. So you see, after 2 months, without any graft, just with the tunneling, coronal advancement, and suturing, we were able to have a good result. This is the 3 months. You see, one of the interesting things is just with the advancement, we even see some increased thickness, even without any graft, because we roll a little bit the tissue, and you see that the tissue is thicker, and we have a good amount of keratinized tissue around the teeth. We had 100% root coverage, and the patient is happy because that yellow recession that he described is no longer there, of course, because we had root coverage. And here you can see the occlusal view. So my second case of VISTA, I'm going to show a case more challenging. So a case that we have attachment loss, so it's not a Miller class 1, but is in this case a Miller class 3. So it means that it's more challenging, it's harder to have complete root coverage, and in many cases you don't have complete root coverage. You have partial root coverage. So it was a patient of mine. She was very unhappy. She knew that she had periodontal disease, so she had been controlled for the last years here in our department, but she was very unhappy with her gingival recessions. So of course, in a case like this, we have to explain our patients that the most important thing is not to treat the gingival recessions, is to control the inflammation. So the first step, this is a patient that had a good control. She was being in the periodontal maintenance recalls every 3-4 months. She had shallow pockets from 3 to 4, but of course you can see, although we don't have severe bone loss, we have mild to moderate horizontal bone loss, and of course that makes it less predictable to treat. You can see these black triangles, so we won't be able to, of course, close those black triangles, and the patient has to understand that we can improve, but we cannot completely close those black triangles because we have bone loss, we have attachment loss. You can also see in the maxilla, the tissue was very thin. So especially in the laterals, the tissue was extremely thin. And for that reason, and especially because it's a class 3, and I have no doubt that when we have class 3 recessions, it's recommended to graft because it's not as predictable as a class 1 and 2. So I think with the graft, you can have better outcomes. Even if the tissue is thick, it's good to graft in cases of Miller class 3. But in this case, you can see that the biotype was thin, so we plan to graft. So again, the first step in our procedure is the vestibular incision. But before we start the surgery, you can see that I did root odontoplasty, and that's a very important step. And many people forget this part. And in cases that are not favorable, if we don't plasty the roots and we have root prominence, it will be very difficult to achieve an acceptable result. And we have evidence here. We have been doing at USC many studies about the influence of root prominence, and we can see that it clearly has a negative effect on the treatment. So here what I did was I did my full thickness subperiosteal tunnel access tunnel, and you can see with VISTA, you can see we have the coronally advancement tension-free, and that's very important, without any perforation. And you can see from the other side the same thing. So this is a very important step to make sure that we go all the way until the molars to avoid any tension and to have enough coronal advancement. So after we have our tunneling, what we do is we suture. We use this bonded suture. So here in this case, I did the bonded sutures with polypropylene 6O. This is a technique sensitive suture. So it's a difficult suture. It's not an easy suture, but with time, it gets easier and faster. What is very important is when we bond to avoid having any blood, any contamination, because if we don't have a good adhesion to the tooth, what happens is after 1 week, these composites, they pop out. And of course, we try to have these sutures in place for at least 3 weeks, usually 2 to 3 weeks. But if we can have them in tension for 3 weeks, it's better. So we have the suturing here. You can see in just one procedure, I do the suturing from molar to molar. So a full arch, soft tissue root coverage. And then we go to the palate. And of course, because we have multiple gingival recessions, we will need a big graft. Here at USC, we try to do it with autogenous connective tissue as much as possible. I think the evidence and the studies show that although we have viable alternatives, connective tissue is still the gold standard. So we try to use it as much as possible. So here we do an incision that will have both the connective tissue from the palate and also the tuberosity. Because in this case, as I said, we needed a big graft. So what I did was I harvested my connective tissue and also the tuberosity. And then what we do is, you see the tissue is very thick, the connective tissue. And we don't need it as thick. So what we do is we thin the connective tissue, and that way, like a sashimi, we have a thinner tissue, which will, in terms of the aesthetics, looks better, rather than if you have a very thick tissue that doesn't look aesthetically as nice. And also, you can increase the length of your graft. So in this case, what I did was I thinned the tissue, and I was able to have a very long graft. And I just went to one side of the palate. So this is just one side of the palate and tuberosity, and I was able to harvest a big graft. As you can see, my graft was able to cover from molar to molar, and that was the goal of this procedure. It was not just to have root coverage, because you know that it's a class 3, we wouldn't be able to have complete root coverage. But the important thing in this case was that the patient had a very thin biotype, and we wanted to stop the progression. And for that reason, we had to graft to increase the thickness and, of course, to change the biotype. So here you can see I did my connective tissue graft, and then we go to the suturing. So the suturing, as I explained, what we do is we go first from outside in. We harvest, we grab the graft in the area where we want to cover. So in this case, usually I suture in the molar area and also in the central incisor area on each side. And in many cases, I also suture in the middle, in the canine area, to make sure that we have the graft stable and close to the tooth. So then what we do is we place the graft in the other side, and we do exactly the same thing as we did in the upper right quadrant. So here we have the suturing, the graft in place. So the patient is ready. In all, this all takes, usually we can do the whole procedure in 3 hours, the whole arch. And I think one of the great advantages of this technique is exactly that. We are able to do a whole maxilla in just 3 hours, and the effect is very good. So you see, after 1 week, this is after 1 week, you can see that there's no sign of necrosis. The healing is favorable. After 2 weeks, you see that the sutures are still in tension, no signs of infection. Of course, one of the limitations is, of course, the patient has to brush gently. In this case, the patient was not doing a good job. She was one of those patients that is so concerned of causing any trauma to the gum during the healing that her hygiene was not ideal. And at 3 weeks, you can see that the sutures were still there. The tissue looks healthy. There's no sign of infection. And at this point, what we do is we take out the sutures. So if you take a look at the before, and if you take a look at the 3 months after, you can see that, of course, we didn't have complete root coverage, but you can see how thicker the tissue is. compared to what it was initially. And if you take a look at the post-op, we were able to have partial root coverage. The tissue looks healthy, much thicker. So I'm pretty sure it will be stable and we will be able to stop the further progression of the gingival recessions that we were having. So this is in terms of gingival recessions using VISTA technique. But as I said, there are other applications of this technique, and one of the applications is frenal surgery, and is actually a technique that me and Dr. Zade, we've developed here at USC, which basically what we do is we use VISTA for frenectomies. But first, let's have a look at the classification and the etiology of the frenectomies and the facts and myths regarding the midline frenum. So usually the most widely classification for the maxillary midline frenum is the classification by Mirko et al., which classifies the frenum in 4 types: the mucosal, the gingival, the papillary, and the papillary penetrating frenum. So the first one is the mucosal frenum. So you can see that the frenum goes until the mucogingival line. Then we have the second type, which is the gingival, where the frenum goes to the attached gingiva. Then we have the papillary, where the frenum goes to the papilla. And finally, the most pathologic type of frenum, it's the papillary penetrating, which is the cases where the frenum goes right until the palatal surface and completely involves the papilla. So in terms of the etiology of the maxillary midline frenum, the pathologic one, usually what happens is you see in those patients that they have the central incisors that erupt widely separated, and what you see is that there is no bone deposited inferior to the frenum. So you can see, and I'll show you some of my cases where you see that like a V-shaped bony cleft between the central incisors and an excessively hypertrophic frenum. In terms of the epidemiology, usually this type of frenum, the most prevalent ones are the mucosal and the gingival one, which are also the less pathologic. And we know that there are several syndromes that can cause pathologic maxillary midline frenum, like Ehlers-Danlos syndrome and other types of syndromes. So the question is, do we have to treat, and when do we have to treat? So first of all, we have to see if it's a pathologic frenum or not. Usually the pathologic frenum are the papillary and especially the papillary penetrating frenum. And usually the question is, when we have the patients with a maxillary midline diastema and they have a pathologic frenum, should we do the surgery before orthodontic treatment or after orthodontic treatment? And the answer is not clear. It basically depends on the type of frenum. So usually the only case where it's recommended frenectomy before orthodontic treatment are cases like this. This is one of my cases where you can see that we have an exceptionally hypertrophic frenum. And the reasons why it's recommended to do the frenectomy before orthodontic treatment is first, because this type of frenum can inhibit the diastema closure. It can be traumatizing and painful for the patients, and it can actually make it faster to close the diastema if we do the frenectomy before orthodontic treatment. Many orthodontists, they are concerned of doing frenectomy before orthodontic reason, and the reason why is there's this general concept that if you do frenectomy before orthodontic treatment, there's the risk that you can section the transeptal fibers, and as you know, transeptal fibers, they are like natural forces that can close the teeth, the central incisors. So for that reason, many cases, they recommend after the orthodontic treatment. So I think one of the few cases where we do it before is exactly these cases, exceptionally hypertrophic frenum. So maxillary frenum is associated with gingival recession. So of course there's not strong evidence, so we don't have systematic reviews, but generally the concept behind maxillary frenum and gingival recessions is that of course when we have a high frenum attachment, and especially in those pathologic like the papillary and papillary penetrating, what happens is because it's attached to the papilla, it retracts the marginal gingiva, and that can cause food debris that enter the periodontal pocket and can cause periodontal disease. Of course, as I said, this can happen, but not always. Having a frenum, a papillary frenum, or a papillary penetrating frenum, we will have gingival recessions. Another consideration for maxillary frenum and possible frenectomy is in edentulous patients when they wear dentures. So we know that in patients that are wearing dentures, of course, we will have to be careful when we do our prosthesis to avoid any trauma in our frenum. But in many cases, we don't have to do frenectomy. Just by having a good adaptation of the prosthesis to the frenum, we don't have to do any surgical intervention. Then we have maxillary frenum and peri-implantitis and peri-mucositis. So some authors like Otto and Gluckman, they suggest that in cases like this, when we have the frenum, like a papillary frenum, that can cause peri-implant mucositis, and the peri-implant mucositis can further progress into peri-implantitis for the reason that it can open the gingival margin, cause more food debris. So it's basically, it can cause a food trap that can cause inflammation, and that inflammation, of course, can cause bone loss. So what are the indications for maxillary frenectomy? So the indications are to prevent the diastema formation, to prevent post-orthodontic relapse after the orthodontist closes the midline diastema. Of course, facilitate oral hygiene in those cases of frenum that can cause food trap, and prevent gingival recessions. We have different, in the literature, we have different surgical techniques for the treatment of frenectomy. So what here at USC, Dr. Zade developed in some of the cases that I was able to do is doing frenectomy with VISTA. And I think this is a very good technique, and we're going to try to publish it because it's a very non-invasive procedure, and aesthetically, I think it looks better compared to other techniques. So I'm going to show one of my patients. This is actually the first patient where we did this technique, the frenectomy using VISTA. So this is a patient that was referred to me by the ortho department, was a young male patient that was referred because he had a very hypertrophic frenum. So you can see this is helps us with the diagnosis of papillary penetrating frenum. You can see the blanching test. You can see the papillary penetrating, the frenum goes all the way until the palatal area. And you can see from the buccal view, you can see how hypertrophic was this frenum. So this is one of the few cases where we do frenectomy before orthodontic treatment. So you can also see that radiographically, the bone cleft that the V-shaped bone cleft that we are able to see in these cases, and also in the periapical, you can see that in the crest, that V-shaped bone cleft, typical in these cases of hypertrophic frenum. So, of course, was a young patient. No, we don't have attachment loss. We diagnosed him with plaque-induced gingivitis. We don't have attachment loss in this case. It was mostly plaque accumulation. So in this case, we have to diagnose the patient, of course, with plaque-induced gingivitis and with aberrant frenum position. In terms of the classification of this frenum, it's one of the pathologic type of frenum. So it's a papillary penetrating frenum with a prevalence extremely low. So it's the one that is less prevalent is the papillary penetrating with a prevalence of 3% in the general population. So our goal in this case, and because it was an excessively hypertrophic frenum, we plan to remove the frenum before orthodontic treatment. In this case, what we also planned was in the same procedure to do a connective tissue graft in the area of a frenectomy. Of course, in this case, the connective tissue graft is not to cover any root because we don't have any gingival recession. The goal is simple. The goal is when we have a frenum, the frenum is mucosal tissue. So when we remove the frenum, we want to have keratinized tissue. And the keratinization in the gingiva is determined by the underlying connective tissue. Those are classic studies from caring. So what we did in this case was we placed the connective tissue to first increase the thickness. It was a thin biotype, and to avoid relapse and better aesthetics. So let me show you the case and how we did this technique, the frenectomy using VISTA. So you see it was a very hypertrophic frenum, and you can also see from the views that it was extremely hypertrophic, and that was that could affect the orthodontic treatment, and it could actually be traumatic for the patient to do the orthodontic treatment before frenectomy. And here this picture shows you clearly the papillary penetrating frenum. So you see that the frenum goes all the way until the palate. So the first step that we do is we do a V-shaped incision, full thickness, to remove the frenum attachment. And you can see the bone. What we do is we create a small tunnel. In this case, of course, is not for root coverage, is to create space for our connective tissue graft. So we create a small tunneling, as you can see here in the video, just in both sides, just to create space for our graft. And then what we do is we harvest a small connective tissue from the tuberosity. It's very non-traumatic, so for these patients, although it's a young patient, we don't even have to suture it, and it's the patients, they don't feel much pain. It heals very fast. So then you have the connective tissue, and what we do is we place the connective tissue inside the tunnel. Of course, because we did frenectomy, we're not going to be able to completely cover our graft, but that's not a problem, because as long as the graft is long enough, we still have enough blood supply to have our graft healing without necrosis. So we leave part of the connective tissue exposed. Of course, here it's completely exposed just to show the graft, and then we place it inside the tunnel. But if you take a look at the healing, so at 1 week, we have what is called the plasmatic circulation, which happens when we have this connective tissue exposed. But it heals very fast. So when we see this, we see that the graft healed. So at 3 weeks, we still see that it's healing, but it healed appropriately. If you take a look at 7 weeks, you can start to see the keratinization in the area where you previously had the mucosal frenum. And you have at 11 weeks, when my colleagues started doing the orthodontic treatment, you can see also that the tuberosity heals very fast. So at 1 week, it's almost healed, and this heals very fast without any problem. So you see from baseline to 11 weeks, you can see that we were able to do our frenectomy without causing any scar, and especially because the patient has a high smile line. But it's also interesting to see the dynamics of the lip change just with the frenectomy. You see that the lip mobility definitely increased just with the frenectomy. And here is the before, and this is the 11 weeks post-op. You can see that we increased the thickness. The tissue was very thin, so we were able to increase the thickness, avoid any scar tissue, and of course avoid any relapse, because in this type of hypertrophic frenum there's always a risk of relapse, and we were also able to reduce that risk of relapse by placing a connective tissue. So then I'm going to show another case where we did the frenectomy after orthodontic treatment. So this case was not as hypertrophic as the previous. So what we did is we did ortho treatment first, and then we did the frenectomy to avoid any relapse. So young patient again, she was referred from the ortho department. Again, we don't have any periodontal concern. So it's a patient with plaque-induced gingivitis, some minor local areas of gingival inflammation. And you can see the patient was referred after orthodontic treatment. In this case, also, you can see that we just did the frenectomy, but in this case, we could also have considered doing aesthetic crown lengthening. That was proposed to the patient, but the patient was happy with her smile. So in this case, we just did the frenectomy. So you take a look, you see this is a type of papillary frenum, so it goes until the papilla. And what we see is that the patient was referred mainly to avoid any relapse. The patient used to have diastema, so my colleagues from orthodontics sent me the patient to perform the frenectomy. So different views of the frenum. You can see it's a papillary frenum, the second most pathologic. And here you can also see the video showing the frenum that we have. So again, this is a palatal view. So in this case, we didn't have that blanching that we had on the previous case, because this case is not a papillary penetrating, it's just papillary, so it doesn't go to the palatal papilla. So here, step by step, again, what we do with our technique is first I did a V-shape incision to remove the mucosal tissue, so the frenum. And then once you remove the tissue, you see you have this bone exposed. So what we do is we create a tunnel using the VISTA instruments. You just need to create a small tunnel to have space for the placement of our graft. And then, again, you go to the tuberosity, you harvest the connective tissue. It doesn't have to be very, very wide. And it's good that you thin it a little bit so that it gets longer, but it doesn't get as very thick, so that aesthetically it will look better. So you see the graft that we place, and then we place it underneath our flap, our tunnel. And as I said, we leave the part of the graft exposed, the connective tissue exposed, and it will keratinize. So this is a 1 month. And you can see that we had a good healing. We were able to remove the high frenum attachment. So it's now way apical. And we have an acceptable result, because one of the problems with the frenectomy is that in many cases with the techniques that we use, aesthetically it looks very ugly. It looks very ugly. So I think one of the advantages of this technique is that first, it's very simple. And second, it improves definitely the aesthetics, and it reduces the relapse. So this is the before, and this is the after the frenectomy. So there are also other applications of this technique, the VISTA. We have been doing here at USC several studies. I've been doing also several studies. So here we have done a comparison of this technique in terms of how does it works in terms of the volume, thickness, and root coverage, we use a software called Geomagic, where what we basically do is we take impressions of our patients before and after the surgery, usually after 6, 12, 18 months, and even more than that. And with those impressions, what we are able to do is we scan those impressions, and with the impressions and the cast scanned, we import those files to a software called Geomagic. And what we are able to do is we are able to superimpose those casts and have the measurement of the changes in terms of the volume, in terms of the thickness. We can accurately measure the percentage of root coverage. So there are many applications of this software. So this is one of the studies that I've done. And also, this is my master thesis project. So I'm doing a randomized controlled clinical trial. I think it's going to be a very good and interesting study. And what I'm doing in my randomized controlled clinical trial is basically I'm going to compare 4 different techniques for the treatment of multiple gingival recessions. So we're going to have coronally advancement flap, which is probably the most widely used one. And then we're going to have also VISTA, we're going to have intracellular tunneling, and we're going to have a group where we're going to treat with VISTA and PRF. So PRF, it's a platelet concentrate that has been used in the last few years in many fields like oral surgery, for extraction sockets, for sinus lifts, for also soft tissue grafts. So what we're going to do, what I'm going to do in my master's study, and I've been doing, is we are randomly doing different types of techniques, and we are going to use the software, the Geomagic software, to superimpose and compare the different techniques and see what is the outcome in terms of percentage of root coverage, but not just the clinical parameters, but also the patient-related parameters, like the post-operative pain, the aesthetic parameters. So those are things that I think lack in the literature, and especially comparing these techniques that are probably the most widely used techniques for the treatment of multiple gingival recessions. So with this, I would like to thank you all. It was a pleasure to be here with you, sharing a little bit of what I have been doing during the last 2 years here at the University of Southern California. And once again, I would like to thank the International Association of Dental Students for this kind invitation. Thank you.
Thank you very much, Doctor. It was an amazing lecture, exactly just like we expected. I would like to ask the viewers right now whether they're free to ask in the comments on YouTube, and we'll then ask the doctor. Maybe you've mentioned everything and no one wants to know anything more. You've explained it all.
I hope so. I hope that's
definitely.
Either everyone is sleeping or everyone understood everything.
I believe they all understood everything. Let's wait a few seconds. Well, so far we have no other questions. Is there anything that you would like to add?
No, I would like to just to say that everyone is welcome. If anyone has any question, to send me emails also. This is my email, carames@usc.edu. And of course, everyone is also welcome if someone wants to visit us here at the University of Southern California and see a little bit of what we have been doing. Everyone is more than welcome.
Okay, we have now some people asking, and I also have one question.
Mm-hmm.
Is there any, because I've noticed in this patient that you that you had,
Mhm.
that there was a relation between a gummy smile and this pathological frenulum, and I
Mhm.
wanted to ask better: is there some evidence of a relation, of an often relation, or?
Mhm. So in this case, as you saw, it was a case of altered passive eruption. So it was one of those cases that it's indicated, and we can do an aesthetic crown lengthening to reduce the gummy smile. And what you see in many cases is that in cases of altered passive eruption, you actually have, in cases, a papillary frenum. But I wouldn't say you have a gummy smile and high frenum attachment in every case. Actually, sometimes if you see, for example, the first case, you remember when I did the frenectomy, it actually increased the gummy smile. So the mobility of the lip was increased by releasing that excessive hypertrophic frenum, and it caused more mobility. So in terms of the gummy smile, it will depend definitely on the etiology, and there are different etiologies, but definitely that in this case we had altered passive eruption with that papillary frenum.
Okay, thank you very much for this amazing answer. Now we have some comments and questions. So first, Dr. Pavel Scarlat is thanking you for the presentation and asking as well if you could share your experience regarding the VISTA technique and allograft materials, or if you could refer to some studies that compare the usage of the connective versus allograft in the aforementioned technique.
So first of all, thank you for your question. So all the cases that I've showed here were done with connective tissue. But definitely we have alternatives, especially when we have multiple gingival recessions, and allografts like alloderm is definitely a viable option. If you ask me regarding the VISTA technique, we don't have any study that compares directly allograft, using an allograft or using connective tissue with VISTA. Because the main reason is here at USC, we mainly use autogenous when it comes to when it comes to gingival recessions. What I can tell you is, if you look at the evidence, it's not allograft, but it's collagen matrix. You have a recent study from J. Perio. I think it's 2016. It's November, December, where we basically what they do is they compare tunneling with connective tissue, not VISTA, but intracellular tunneling, comparing connective tissue with collagen matrix, and what they were able to find is that they had a mean root coverage of up to 80%, but when it comes to complete root coverage, they show in their randomized study that when you use connective tissue, you have more complete root coverage compared to when you use other materials, like in this case was collagen matrix. In terms of allograft, to answer your question, I don't think we have studied to directly compare both. Especially with VISTA, we don't.
Okay, thank you very much. There are more questions. Nadia Alves says, muito obrigada. Then we have another thanking comment. And one question from Duda is, how long is your follow-up? When did you remove the suture? And thank you for sharing the knowledge.
So what we usually do is, when we do VISTA for gingival recessions, what we usually do is we take the sutures 3 weeks after. So, of course, if after 2 weeks the sutures are not in tension anymore, it doesn't make any difference and you can take them out. But usually when I suture, I try to suture in a way that we will try to have tension for 3 weeks. So the 3 weeks. In terms of the follow-ups, the cases that I have, the follow-ups, we have up to 6 months, which as you know, usually most of the changes that you will observe happen in the first 6 months. Actually, in the poster that I've showed you, we clearly show that with VISTA, we have up to 18 months, but usually the major changes that we see are during the first 6 months, which is in line with other techniques.
Okay, thank you. I believe you've answered perfectly the question. If anyone else has other questions, you're more than welcome to comment. There's my friend who's asking me right now, and he's trying to formulate the question, so.
Okay.
Okay, so it's about alimentation after the treatment. What are your recommendations after the treatment? What should the patients eat or not eat? And yeah, what's the diet afterwards?
So it's very important. This type of techniques in all soft tissue grafts, it causes a lot of swelling and bruising. And especially, of course, if you do in cases like I showed you, full large soft tissue grafting, of course, we will expect major swelling and bruising. In terms of the post-op, I'm going to start with the medication. What we usually, our protocol, although we know that for soft tissue grafting, the incidence of infection is extremely low. So we have a study from Powell that shows that the incidence is less than 3%. When I have these cases of multiple gingival recessions, full mouth, I always like to prescribe antibiotics. I prescribe ibuprofen for the inflammation, and I prescribe a mouth rinse, in usually Periodontal, so chlorhexidine, because of course it will be harder for the patient to brush. In terms of the oral hygiene of the patient, of course, because this type of sutures is polypropylene 6O, and because it has the composite, the patient has to be very gentle when he brushes the teeth. So I don't recommend any electric toothbrush. I recommend a manual toothbrush, and try to brush gently the tooth and not the soft tissue. In terms of the diet, what I recommend is soft food, especially for the first 3-4 days. I ask them avoid anything that is very hot, like hot coffees, avoid spicy food or acid food or drinks, and that's basically and a lot of ice packs. That's very important, especially during the first 48 hours, 24 hours to 48, and that's usually my recommendation.
Thank you. I suppose that smoking as well, you
Yes.
do not recommend afterwards.
When we have smoker patients, we are very cautious doing this protocol of full mouth root coverage, and especially in cases that we have, for example, the case that I showed, it was a very unfavorable case, middle class 3 with attachment loss. So we know that smoking definitely affects negatively the outcome. So in cases of heavy smokers, probably in many cases we don't do soft tissue graft if it's a class 3 with severe attachment loss. So in these extreme cases, if it's a smoker, either there's a severe inflammation and the patient cannot brush, or we try to avoid it.
Okay, and the very last question that we received is about the material that you use to attach the suture to tooth. It was flowable composite, right? If I remember well.
Yes. So usually what we use is flowable composite, and what I do is I just etch and then I bond it. So, and it's flowable composite, and usually it's very easy to take them out after 3 weeks. We don't even need to use a burr. Just with the probe, we usually are able to pop them out.
Perfect. No, I'm sorry. Actually, there's another question from Diana. Is VISTA technique a better way to remove frenulum than laser?
That's a good question. So laser is very popular here in US, not just for frenectomies, but for other application. I think I see laser as a tool. So laser can help you in several procedures like frenectomy, even it's used in other applications like decontamination of implants, intraosseous defects. I think you should see laser as a tool. I don't think it's better, and we don't have in the evidence. We don't have evidence in the literature that says that clearly says that laser is better. I think it's a tool, but the outcome, I think it's pretty much the same as if you use a blade or you use a laser. The only great advantage is the bleeding. So for frenectomy, it's not a big deal, but in some cases that there's patients that have a lot of bleeding that are taking medication, definitely laser helps.
Thank you very much. Thank you very much for this enriching lecture. It was a huge pleasure and honor, and we really appreciate the effort you made. And I personally wish you a lot of luck in the follow-up research that you're doing. And we hope to maybe welcome you next time in our IDS webinar again.
Thank you very much. It was a great pleasure to share this webinar with you.
And if there are no more other questions, this would be it. Everyone who just missed a few details and wants to rewatch the lecture, it will be available on YouTube. And obrigado.
Obrigado. Thank you.